Hey guys, we are still in the concept of perfusion, and in this lecture, we are going to talk about heart failure. Heart failure is also called cardiac failure or pump failure. You still hear it called congestive heart failure or CHF, but we are moving away from CHF because not all patients have congestion. It depends on the type of heart failure. Heart failure occurs when the heart is unable to generate cardiac output sufficient to meet the body's demands. As we work through heart failure, think about the heart as a pump that is failing. Heart failure is also called cardiac failure or pump failure. You still hear the terms congestive heart failure or CHF, but remember, we're moving away from that because not all patients have congestion. It depends on the type of heart failure. So as we move through this lecture, you're going to see how heart failure affects the heart's ability to generate cardiac output sufficient to be able to meet the demands of the body. Think of it as the heart is failing to pump blood forward and heavy fluid is backing up into the lungs. Now this can be super deadly since the patient can end up drowning in their own fluids. But if we can recognize it, we have some interventions to treat or rescue the patient from the fluids they are drowning in. Now for right-sided heart failure, think R for rocks the body with fluid, also called peripheral edema. And L for left-sided heart failure, think L for lungs, also called pulmonary edema. Now the problem, guys, here is the fluid. Since we have a fluid problem, we have to think any weight gain we have as water gain. You have to think water gain when you're talking about heart failure. Over 1 to 2 pounds in one day or 3 to 5 pounds in 7 days is very, very bad, guys. Accurate daily weights are needed. 1 liter of fluid can equal approximately 2 pounds. So you have to do daily weights on these patients to monitor these patients. If weight is bad because it means water, think daily, not weekly. It is possible to gain 10 to 15 pounds before edema is apparent. So 1 to 2 pounds in a day or 3 to 5 pounds in a week is a concern. Key words as well. Any words like new, sudden, rapid, or worsening indicate a priority patient and when we're talking about heart failure. So if the body gets rocked with fluid, we can see peripheral edema. We usually see edema or pitting edema, basically fluid buildup in the lower extremities, usually in the lower legs. The edema starts in the extremity and then can ascend upwards. Basically, blood is backing up in the vena cava. Shoes and rings become tight, and if the patient's on bed rest, we'll see the edema where? That's right, it will become dependent in the sacrum. The body also gets rocked with fluid. We can see JVD, or jugular venous distension. So how do you assess for JVD? If the patient's supine with the head of bed at 45 degrees, you can compress the upper right abdomen for 30 to 40 seconds, and you'll see a sudden distension of the neck veins if the patient has right-sided heart failure. And as the body gets rocked with fluid, we can even see some abdominal growth from the fluid buildup. Now this is called ascites or hepatomegaly or splenomegaly. This is abnormal accumulation of fluid in the peritoneum. What procedure would we do if too much fluid accumulates? That's right, a paracentesis, and fluid volumes can reach up to 10 liters or more, guys. That's a huge amount of fluid that the body's holding on to. With enlarged liver and spleen, sometimes we see these patients may have GI complications such as nausea, vomiting, and anorexia. Now for left-sided heart failure, think L for lungs or pulmonary edema. Now this one's more serious since it affects our ABCs, the airway and the breathing. So we hear crackles or rales, which is fluid buildup in the lungs. This isn't rhonchi and it's not wheezes, it's crackles. We see two other key words for left-sided heart failure. Frothy pink or blood-tinged sputum is always a classic sign of pulmonary edema, as well as the two penias like dyspnea, which is difficulty breathing, and orthopnea, which is shortness of breath while lying flat. So there's many different ways to classify heart failure, but we're going to talk about right-sided heart failure versus left-sided heart failure in this lecture. Heart failure is caused by hypertension in the majority of the cases, and also after a myocardial infarction when parts of the heart muscle have been damaged and no longer function metabolically or mechanically. Since the blood is not being moved through the heart and out into general circulation, it backs up into the lungs, and we see several symptoms because of this. First is cough, an irritating nighttime non-productive cough. We also can see orthopnea, which is dyspnea at rest in a recumbent position. We may see paroxysmal nocturnal dyspnea. The patient suddenly wakes up at night with shortness of breath after being asleep for a while. That's because that fluid that is dependent during the day is reabsorbed and back into the vascular system, and the heart just can't handle it. We may see dyspnea on exertion, or DOE. We may see pink or frothy sputum, which happens because there's an overload of blood in the vessels of the lungs. The blood is pushed back into the pulmonary capillaries and into the alveoli and bronchi. And then we may see fatigue and weakness, where the tissues just are not getting enough oxygen. You can assess activity tolerance and the ability to perform ADLs, and the patient may complain of heaviness in the arms and the legs, or just general fatigue. You may see confusion, restlessness, and dizziness, all because of decreased perfusion to the brain. The patient may present with angina because of decreased myocardial perfusion, and the patient may have oliguria because of decreased renal perfusion. That blood is just not perfusing the renal, so they're not filtering. And then you'll hear crackles in the lung, which sound like this. Keywords, guys, these indicate your patient is sick or getting sicker. These indicate the patient is worsening and can indicate the patient's status is getting very severe. When you hear words like new, sudden, worsening, or rapid, such as new pink frothy sputum, worsening crackles, rapid weight gain or rapid water gain, or even new peripheral edema. Even though we talk about heart failure as right versus left-sided heart failure, there are two categories of left-sided heart failure that you need to be aware of. Systolic heart failure, which occurs when the heart cannot contract forcefully enough during systole to eject adequate amounts of blood. The left ventricle is all stretched out like an overused rubber band and has lost its stretch. The ejection fraction drops from a normal of 55 to 65% to below 40%. This is also called forward failure because the blood is backing up into the lungs. The second subcategory is called diastolic heart failure, With diastolic heart failure, there's an inadequate relaxation or stiffening of the ventricles that prevents it from filling with sufficient blood to ensure cardiac output is adequate. The ejection fraction is okay, but there's less volume to begin with. So don't just assume that if the ejection fraction is normal on an echocardiogram, the patient does not have heart failure. Since worsening heart failure is a huge emergency due to the lungs being filled with fluid, which compromises your ABCs, you should write this down. The number one treatment is always ide-ending drugs like furosemide and this B one. They both end in ide, so think the body dried. So for anyone with worsening heart failure, we use the acronym HOPE. H is for head of bed, 40 to 90 degrees, called semi-Fowler's or high Fowler's or orthopneic position. O is for oxygen. P is for we push furosemide and even morphine, which decreases the workload on that heart. And E is for N sodium and fluids, aka sodium and fluid restrictions. So no drinking extra fluids, and we're stopping all IV fluids. All right, guys, some testing tips for some things that you should know that show up on nursing tests regarding worsening heart failure. Number one, how does the nurse know if the treatment was successful? Well, we're going to hear clear lung sounds and have a decreased heart rate. Number two, we should always question a doctor's order that they want to give fluids, even maintenance fluids. It's a huge no-no for worsening heart failure. Number three, when transferring a heart failure patient to another unit, we're always reassessing those heart and lung sounds. Reassess any patient who's transferred to another floor. And number four, sodium swells the body. So nothing from a package. No chips, no canned food, no sauces or dressing, meats, cheese, nothing over the counter. That's right, not even any cold or flu medication, no Tums, no acetaminophen, and no NSAIDs. All right, let's jump into a little review of the patho and causes of heart failure. If you understand drugs like ACE inhibitors and diuretics, you'll understand what the treatments and why the treatments for heart failure are so important, and you'll also be able to be prepared to answer these types of questions on nursing tests. So let's understand how the body normally functions really quick. So remember, the veins vacuum deoxygenated blood back to the right side of the heart to get more oxygen from the lungs. And the left side of the heart pumps that oxygen-rich blood out to the left side of the body. This is what we call cardiac output, meaning oxygen-rich blood out to the body to oxygenate the tissues. Now, the number one risk factor in heart failure is always hypertension, that high blood pressure or that high tension on the heart. But usually heart failure is caused by anything that will cause a dysfunctional pump, and this causes fluid to back up. This can be things like valvular dysfunction or even dysrhythmias like atrial fibrillation. Even all the cardiomyopathies. Dilated cardiomyopathy, which is systolic failure, reduces the ejection fraction because that weak chamber can't pump effectively. This is often due to hypertension, myocardial infarction, infection, even chemotherapy and alcohol abuse. Restrictive cardiomyopathy or diastolic failure preserves the ejection fraction so that may be normal, but there's just not enough blood for cardiac output to be sufficient for the body. A lot of times it's hypertension and diabetes that lead to the thickening of the ventricular wall, which cause that restrictive or diastolic heart failure. And then hypertrophic heart failure is less common, and it's really of genetic origin, and the heart just can't relax. In all the cases, the heart's not able to pump the blood forward effectively, and that's when things really start to go wrong. Now, more specifically for causes, Left-sided heart failure is caused from damage to the myocardial heart muscle, making the heart weak and causing a weaker pump, usually from MI, where the heart muscle dies and now the muscle can't contract at all. So we commonly get heart failure after a big heart attack or ischemic heart disease before a heart attack, like we see in coronary artery disease, acute coronary syndromes, where the plaque builds up on the wall, narrows that blood flow, and that heart wall muscle just gets less oxygen over time. So again, let's review really quickly. Heart failure caused by a big heart attack or ischemic heart disease like we see in coronary artery disease or acute coronary syndromes. We're just not oxygenating that left ventricle very well due to the plaques and the narrowing of the coronary arteries. So this is the biggest cause of systolic heart failure, meaning squeeze failure. Basically, the heart cannot squeeze enough blood forward out into the system. So fluid fills the lung, causing pressure, and this is what we call pulmonary hypertension. As a result, the right side has trouble pumping blood forward. So left-sided heart failure commonly causes right-sided heart failure, aka cor pulmonale. Or right-sided heart failure can also be caused by diseases of the lung, like COPD from years of smoking, or things like obstructive sleep apnea. So we know if the heart fails to pump blood forward, that means less cardiac output, meaning less oxygen to the body. As a result, the kidney gets less blood flow and falsely think the body has low blood pressure or low blood volume. So it mistakenly increases the already high blood volume by both stimulating the sympathetic nervous system to increase the heart rate and constrict the blood vessels, and also by initiating the RAS system, which retains fluids by locking the kidneys and constricting the blood vessels. So now we have two problems here: an already weak pump with increasingly high volume, which leads to higher pressure. So what are the effects? Well, stroke volume is increased because of the increased contractility that occurs with stimulation of the SNS. Each of these things that occur are as a result of increased SNS stimulation has a downside. You can only increase the heart rate so much before diastolic filling time is decreased. Myocardial oxygen requirements are increased when the compensatory mechanisms occur. The RAS system, or the renin-angiotensin-aldosterone system, increases sodium and water retention, which increases both preload and afterload. And vasoconstriction is increased with angiotensin II, which increases afterload. Again, oxygen and demand on the heart is also increased. The immune response causes inflammatory cytokines to be released, which contribute to ventricular remodeling. Ventricular remodeling is when the size and shape of the left ventricle is changed, which decreases the function of the LV, or left ventricle. Endothelium is released when the heart cells are stretched, and that acts as a vasoconstrictor, which increases afterload and hypertension, and again, heart failure will worsen. BMP, or brain natriuretic peptide, is released in response to the stretching of the walls in the ventricle, and that's actually a good thing. It promotes vasodilation and diuresis to help decrease preload. It counterbalances that RAS system. And myocardial hypertrophy is the final compensatory mechanism. The walls of the heart thicken and provide a more forceful contraction. This is something that occurs slowly over time. All of these compensatory mechanisms increase the demand for oxygen in the heart. And when that demand cannot be met, compensation no longer takes place and heart failure occurs. Demand cannot be met, so compensation no longer takes place and the patient starts to go into the severe heart failure. Oh, snap. This is usually on many nursing tests, so you got to know this. One of the main culprits is the RAS system, or the Mr. Aldosterone system. We call him AL for short, since he adds sodium and water in, which increases blood pressure, and he lets potassium out of the body and into the potty. So we end up giving drugs that block or cut the communication lines to aldosterone. Drugs like prils, sartans, and acetone-ending drugs. Without AL in the mix, we don't end up adding water in the body, so we end up losing it in the potty. But now we hold on to too much potassium. This is a big nursing tip here, guys. All of these drugs lead to potassium retention. We're talking potassium levels over 5.0. So ACE inhibitors like lisinopril, think P like potassium sparing, also S as in spare that potassium, like sartans as in losartans, which is an ARB, and spironolactone, which is a diuretic. So think S for spares the potassium. All right, guys, let's talk diagnostic lab here. And one of the most important heart failure labs that you need to know is BNP, B-type natriuretic peptides or brain natriuretic peptide. The higher the BNP, the worse the heart failure. But BNP is a drug that can also be administered to do the same thing when it's released naturally from the body. As those ventricles stretch and overfill with fluid, BNP is released, causing vasodilation and diuresis through sodium loss. Think big bulging ventricles here, guys. We're talking 100 or less on the BNP is normal. 300 or more is mild. 600 or more is moderate. And keyword here, 900 or more is considered very severe. So as those ventricles bulge, they start to secrete BNP under heavy pressure. In addition to BNP, you also need to consider electrolytes as well, because electrolyte alterations may occur because of the heart failure itself, or because some of the heart failure medications we put these patients on, such as ACEs, ARBs, and diuretics. We can also do some non-invasive diagnostic tests. The echocardiogram is great for measuring the size of the left ventricle as well as the ejection fraction. Remember, the ejection fraction is the amount of blood being ejected from the left ventricle in one pump, and it's measured as a percentage. So 55 to 70% is normal, and anything 40% or less is usually indicative of severe heart failure. Patients with symptoms that are suggestive of heart failure should have an echo, even if there are not a lot overt symptoms of heart failure. The echocardiogram, again, measures that ejection fraction, or the portion of blood that's ejected out from that left ventricle with each contraction. Remember, EF is only affected in systolic heart failure, and it's normal or preserved in diastolic heart failure. But that doesn't mean that the patient doesn't have heart failure, guys. You need to know the difference between systolic and diastolic heart failure, and in which one EF is lower and which one EF is normal, and the why there's a difference there. Another quasi non-invasive diagnostic test is the transesophageal echocardiogram, or TEE. It's a special type of echocardiogram. Just like an echocardiogram, it uses high-frequency sound waves or ultrasound to examine the structures of the heart. Being overweight or having certain lung disease can interfere with images of the heart when a transducer is placed on the chest like you see in a traditional echo. So certain conditions of the heart are seen better in a TEE, such as mitral valve disorders, blood clots or masses inside of the heart, a tear in the lining of the aorta, and structural and functional problems with artificial heart valves can all be seen better with TEE. So when we have these special cases where we have patients who are overweight or have these lung diseases, then we may choose to do a TEE over a traditional echocardiogram. Remember, like we talked about in the beginning, the number one goal in heart failure is to drain that heavy fluid. So we can do that in two ways. We can do it with drugs and with lifestyle changes. So we'll start with lifestyle changes, but remember, this is perfusion and our goal should do everything to optimize oxygenation. So we can give oxygen to get those sats above 92%, That's our guideline. We want SATs in CFH patients higher than 92%. We also want to keep that head of bed up. We want to assess the heart and lung sounds carefully and thoroughly. We want to turn, cough, deep breathe every 2 hours, and we need to listen to those heart sounds. An extra sound of S3 is significant in CHF, and we need to listen for that improvement of crackles. So diuretics are used when fluid restriction is not enough. Diuretics enhance excretion of sodium in water by reducing circulating volume and causing a decrease in preload. This reduces systemic and pulmonary congestion. The type of diuretic depends on the degree of heart failure and renal function. We usually start with thiazide diuretics, especially in older patients. Onset of diuresis is more gradual in the thiazides. Diuresis decreases after the edema fluid is lost, thus dehydration that may occur with loop diuretics is less common in thiazide diuretics. But loop diuretics are important and the #1 indicated diuretic for use in acute heart failure. So when they come to the AER, the patient always gets Lasix IV push and they usually get a Foley. So when we have a CHF patient who's on fluid overload, we want them dried. So we give them an eyed diuretic to drain that fluid from the body and into the potty. So remember, furosemide makes the body dried. This is always a test favorite. Know the difference between treatment of acute and treatment of chronic heart failure. And remember, worsening CHF, anything like worsening crackles, new edema in the legs, and rapid weight gain all indicate worsening heart failure. We have to monitor the patient, so you have to monitor for hypokalemia, general weakness, depressed reflexes, irregular heart rate. Pharmacological interventions include ACE inhibitors, which are almost always given to patients even with mild heart failure. These drugs decrease preload and afterload. ACE inhibitors like lisinopril, we call it the chill pril for the heart. It lowers the blood pressure but not the heart rate. Remember, prils put the blood pressure on low. Next up, we give dilators. Dilators like vasodilators like nitroglycerin, commonly given in chest pain but also works in heart failure to lower the blood pressure. We also give cardiac glycosides like digoxin. Our positive inotropic drug, digoxin, digs for that deeper contraction or increased contractility. So remember, digoxin digs for a deeper contraction, usually given to patients in systolic failure or that squeeze heart failure to help with that more forceful contraction. Next up, we get beta blockers. They can be given, but we must be careful because they can actually worsen symptoms of heart failure. They're sometimes helpful when there's increased levels of sympathetic stimulation in patients with the release of catecholamines. Remember, our beta blockers put the brakes on the heart, and they're the beta blockers ending in LOL like atenolol. Think double L's for double lows, low heart rate and low blood pressure. So when we give beta blockers, we always check the heart rate and the blood pressure before giving them. And our other treatments can be remembered by a good old acronym, Dr. Beds. So D is for diet, that low sodium and low fluid. Remember, sodium swells. So 2 liters of fluid, or about 8 cups, and 2 grams of sodium or less per day. This means no fried foods like fried chicken or French fries. We are choosing grilled chicken instead, and no canned or packaged foods. Anything from a package is a big no-no, such as chips, sauces, meats, cheeses, or wine. Even canned vegetables and canned beans. Speaking of canned, avoid all over-the-counter medicines. They can have a lot of sodium. So C for cold and flu, A for acetaminophen, A for antacids like Tums, and N for NSAIDs like ibuprofen or naproxen. Some doctors may prescribe and allow oxygen. Some doctors may prescribe and allow aspirin, but just remember, guys, it has sodium. Now, patients will return to the hospital over and over again because they cannot avoid salt and end up in worsening heart failure. So educate your patients. Sodium swells, so avoid sodium. Eliminating table salt will bring the sodium down to about 3 grams per day. Eliminating salt in cooking and high sodium foods will bring it down to around 2 grams per day. R is risk for falls or orthostatic hypotension. Remember, slow position changes. B is for blood pressure and BMP. These numbers should not be increasing. If they are, this is an immediate call to the doctor for notification. E is for elevate the head of the bed and elevate the feet with pillows. We're talking high Fowlers to help the patient breathe. And while we're moving, don't forget, turn, cough, deep breathe every 2 hours and keep that head of bed elevated. D is for daily weights, not weekly. This is very important, guys. These weights are daily. Weight gain means water gain. So anything over 1 to 3 pounds per day or up to 5 pounds in 7 days indicates worsening. These gains are very bad and the physician needs to be notified. S is for sex. We need to educate our patient, and the key word is only after they can climb 2 flights of stairs without shortness of breath. And finally, that last S is for stocking or TED hose. This decreases blood pooling. Remember, we remove these daily and we apply them before getting out of bed. Oh, and never massage the calves of a CHF patient. All right, so as far as treatments, we need to make sure we monitor those vital signs and response to activity regularly. We need to determine the patient's physical limitations and encourage activity consistent with the patient's energy resources. We need to optimize that energy, so observe for activity intolerance, alternate rest and activity, teach techniques of self-care that will minimize O2 consumption. And then there are some other treatments for more severe cases. CPAP, or continuous positive airway pressure, can be useful in the management of patients suffering from an acute CHF episode. CPAP improves the ability of alveolar diffusion of oxygen into the red blood cells and thereby maximizes oxygenation. We also may see CRT, which is cardiac resynchronization therapy, which is done by putting in a device like a pacemaker that synchronizes atrial and ventricular contraction to maximize cardiac output. And in very severe cases, the patient may get an LVAD, or a left ventricular assist device. First, these were only used for those awaiting heart transplants, but now they've shown to improve survival rates, and they are sometimes considered for patients who are ineligible for transplant. An experimental treatment involving stem cells involves injecting the stem cells from a patient's own blood marrow into the heart via a catheter, has brought significant improvements in a handful of patients who've received this therapy. Specific to LVAD, the main function is to support a failing heart until a donor becomes available for transplant. The LVAD gives the heart muscle time to rest and recover. The newer LVADs allow the patient to be at home. These devices are implanted directly into the heart, and a wire comes out of the body where it can be connected to an external power source that the patient wears. All right, guys, time for knowledge check. In a patient with heart failure who's constipated, what would the nurse recommend? A, walking, B, increased fiber, C, stool softeners, or D, drink extra water? All right, when you're thinking about the response to this question, think heart failure is in heavy fluid. Remember, sodium swells. So a patient with heart failure is constipated. What should the nurse recommend? Well, walking, increased fiber, and stool softeners are all good, but remember we have to avoid that extra water. All right, now let's check again. Which food items should the heart failure patient avoid? A, chips, B, fruits, C, vegetables, or D, grilled chicken and fries? Which food items should the heart failure patient avoid? If you answered A and D, then you got it correct. Remember, no chips and no fried food. Nothing that's deep fried, even French fries. And while we're here, no canned beans and no packaged foods either, remember. All right, let's jump into another knowledge check. A client with chronic heart failure took cold medicine for her flu. She presents with new productive cough, with pink frothy sputum and worsening crackles. What action should the nurse take first? A, assess lung sounds. B, give butamide IV push. C, notify the physician. Or D, clock out and go to lunch. All right, guys, the patient is in extreme heart failure, meaning heavy fluid. We need to give that ide-sounding drug to make the body dried. So the correct answer is B. All right, guys, we've covered non-pharmacological interventions and lifestyle changes and a little bit of pharmacology. If you haven't watched Pharm lectures yet, you should watch cardiovascular pharmacology and cholesterol-lowering agents, because both of those will help you in your understanding of how we're treating heart failure patients. So we've covered several topics under the concept of perfusion as we've been discussing coronary artery disease, coronary intervention, heart rhythm problems, heart failure, and cardiac pharmacology. Now it's time to review and study these concepts to make sure you're prepared and ready for exam 3.